let's go ahead and get started with our first speaker. And quite honestly, it is such a privilege to introduce a good friend, Dr. George Willis. George, as many of you know, was faculty here in the Department of Emergency Medicine here at Maryland for many years before relatively recently relocating to Texas. George is currently an associate professor and associate program director at the University of Texas Health Science Center at San Antonio. After he completed residency with us here at Maryland, George stayed on as chief resident, where he also completed our faculty development fellowship. And then he has gone on to be widely known across the world for his expertise, his niche in endocrine emergencies within emergency medicine. But many of you also may not know that he has expertise in vascular emergencies. And that is what he's going to speak on this morning with respect to our cardiovascular emergencies. George has won a plethora of awards, not only from ACEP, but also AAEM, and was relatively recently named by EMRA as one of the top 25 under 45 influencers in emergency medicine. So, George, my friend, with that, I can't wait. I always learn so many important things from you. Take it away and get us started here on our Emergency Cardiology Symposium, talking about aortic dissection.
Mike, as always, it is a pleasure to be here. Wonderful to see so many friendly faces. I miss my Maryland people, so it is an absolute pleasure to be here today to lecture about something that I'm extremely passionate about, which is aortic dissection. So I'm going to share my screen, and we'll get started. So I like to start my talks off with a case. So you're working in the emergency department, and a patient comes in. He's a 45-year-old gentleman. He has hypertension, hyperlipidemia. He's not the best at taking his medications. He's decent, but not great at it. While he was at work today, he experienced a sudden onset of some chest pain, shortness of breath, and he was very, very diaphoretic. He was concerned enough that he actually left work and presented to the emergency department. And you walk into the room and you feel a little uncomfortable. Your spidey sense is going off and you're tingling a little bit, thinking about the fact that this relatively young gentleman looks really, really uncomfortable. So you look at his vital signs and you notice that his vital signs aren't too bad. His blood pressure is 128/63. His heart rate's 84. His respiratory rate is a little higher, and you actually counted it, and it's actually 24. It's not the standard 20. Afebrile. But the thing that keeps going off in your head is he's very diaphoretic. So the first thought that goes through your head is, surely this must be acute coronary syndrome. So you get the EKG, and it actually doesn't look that bad. He doesn't really show you any ST elevations or ST depressions. There's that isolated T-wave inversion in lead 3, and AVF has some T-wave flattening. And you're thinking to yourself, okay, so his EKG isn't normal. He's diaphoretic. He's got chest pain. Surely acute coronary syndrome has to be high on the differential. So you get some lab work, and the lab work starts to come back. He's got a mildly elevated white blood cell count. His high sensitivity troponin, which is a little bit elevated, a lot more elevated than what your standard is. So our cutoff here at UT San Antonio is 15. So this is obviously a lot higher than that. Lactate's a little elevated, but thankfully his D-dimer is normal. So you think to yourself, surely this patient may be having some element of acute coronary syndrome, and we should probably admit him to the hospital. So you call your hospitalist and say, hey, I have a gentleman here who has chest pain that is a little concerning for acute coronary syndrome, and you admit him to the hospitalist. So you go home, you finish your shift, and you start to go over your notes because you have some charting that you need to finish. Surely you look at the chart, and as you're looking at the chart, there's some things that are starting to concern you. First and foremost, the patient apparently went into cardiac arrest. He went into cardiac arrest. It was noted that he was in PEA. They gave him epinephrine. He subsequently went into VFib, but then subsequently went back into PEA. Unfortunately, they were unable to get return of spontaneous circulation and unable to resuscitate him, and he subsequently passed. The ME thankfully took the case because you're a little intrigued as to what potentially happened. In your head, you're thinking, well, this patient had acute coronary syndrome. Most likely, he may have gone into some kind of malignant arrhythmia and subsequently, as a result, passed because of that. So you think everything seems okay. The medical examiner takes the case, and everything seems fine. And then you go on about your days, continue to weeks, into months, and then you get the sharks who are chasing after you. And sure enough, after 2 years, you get a subpoena from the plaintiff lawyer looking at this case as a potential case for medical malpractice. Now you're thinking in your head, surely I did everything correctly. This patient who had chest pain, he was diaphoretic. Surely I thought of every single thing that could have been a potential otherwise that may have caused this patient's untimely demise in the emergency department. But you don't necessarily remember all of the things that you may have documented or didn't document in this very bad case of a patient who subsequently had died from an aortic dissection. So we're going to talk about keeping the sharks at bay, keeping those plaintiff lawyers at bay with documentation pearls, and certainly things to help minimize your risk of missing aortic dissection in this very, very critical patient population. Now we know how aortic dissection happens. We know that there's an intimal tear in the aorta, and that intimal tear somehow ends up propagating further down, and the intimal flap can either just stay there, or it may go across other aortic branches, causing subsequent malperfusion in patients who come in with chest pain. The problem with aortic dissection is it's a very difficult diagnosis to make. Why? Well, first and foremost, oftentimes we don't think about it. And the reason we don't think about it is because there's so many other things that are much more prevalent in presentations to the emergency department. Aortic dissection is one of the rarer causes of chest pain that we see in the emergency department. However, it is the most common aortic disaster. We think of AAA being something that we may see in our emergency department shifts, but dissection is actually much more common than even rupture AAA. And we'll hear about rupture AAA shortly on this cardiology symposium as well. So if we don't think about it, we will oftentimes miss it. But the other thing about aortic dissection is it's very, very sneaky. And as you can see here, the aortic dissection will rip through the protective layer of what we have in our aorta, and it sneaks into our vessels, it sneaks into other perfused organs and target organs, subsequently causing other symptoms that may mask what's actually going on with the patient. As a result of the omission of thought, as a result of the sneakiness of aortic dissection, the mortality is actually very high. So 30% of patients will die from dissection. And unfortunately, about 20% of patients actually don't even make it to the emergency department and die in the field. Now, when it comes to malpractice, aortic dissection is actually one of the higher things that people get sued for, most commonly in the emergency department. Here's a paper that was published in Vascular Endovascular Surgery in 2022, hot off the press, January of 2022. And what it found in this kind of the systematic review of different cases that have presented to malpractice cases for aortic dissection is that there's some common themes here. First and foremost, the group that gets sued more commonly than any other specialty is emergency medicine. 41% of these lawsuits are against the emergency physician. Now, other people get sued as well, the internist who may have admitted the patient, cardiologists if the patient was thought to have ACS and get heparin or thrombolytics or catheterization. But we are commonly the most common culprits in malpractice cases for aortic dissection. Unfortunately, as a result of that also, 72% of the reason why is for a failure to diagnose and treat. So oftentimes we misdiagnose this aortic dissection into something else. Commonly, it's going to be some other thing that we may think about. So 11% of the time it's cardiovascular. 9% of the time we call it musculoskeletal chest pain, or 9% of the time we call it gastrointestinal chest pain. But the far most common reason why people think that they misdiagnose aortic dissection as is unknown. So that's the chest pain NOS, the abdominal pain NOS, the back pain NOS. That was the most common misdiagnosis for patients who came in with dissection. We're not that great in terms of defending ourselves either. So about 41% of the time, the ruling is for the plaintiff, which means that a little bit better than half of us actually are successful, but the large minority of these, will be ruled for the plaintiff or ruled for in a settlement to the tune of $1.3 million on average in terms of what these patients actually get or their families get as a result of things that we misdiagnose. Now, in terms of protecting ourselves from mitigating our risk for aortic dissection, especially with malpractice, it all comes down to the documentation. The documentation is the thing that's paramount in terms of what plaintiff lawyers look at to see if we actually thought of this diagnosis. The thing that we have to remember with malpractice cases is that oftentimes we defend ourselves on our documentation and this case will just go away. But we oftentimes think that the less we document, as long as we can say, I don't think that this person had an aortic dissection during the deposition, we may get away. But that is very, very far from the truth. So let's talk about the things that we need to make sure that we're looking for to obviously mitigate our risk of missing the dissection, but also things that we need to make sure that we document when we're seeing these patients who come in with chest pain or back pain or abdominal pain to make sure that if we get sued, that we will not have anything that will go badly against us. So let's start with the tools that we have access to. Let's start with the history. History is very important. It brings about pitfall number one: failure to document the adequate pain history in detail. Whenever I see a patient who comes to the emergency department with any type of pain complaint, the most important thing that I make sure to document is OLD CAR. OLDCAAAR. Those stand for onset, location, duration, character, alleviating factors, aggravating factors, associated symptoms, and radiation. Now, some of you may use OPQRST. That's perfectly fine as well. This is the one that I typically use. But anybody who presents to the emergency department with a pain complaint, I actually will list OLD CAR on my chart and make sure that I ask the appropriate questions and also document them on the chart. Now, let's go through OLD CAR with dissection to see things that we may get on the history that may make us think about dissection, but also things that we can document to help us in case we have a malpractice case come against us. Starting with onset. Most of the time, patients who come in with aortic dissection will have acute onset of torso pain. So it's not just chest pain. They may have back pain, they may have abdominal pain, but it is almost always acute in onset, sudden in onset. I call this the thunderclap headache of the torso. In other words, the subarachnoid hemorrhage of the torso. Not only does the patient have the acute onset of pain, but also maximum severity within a small amount of time. So if their pain gradually onsets over a period of time, that's less likely to be aortic dissection. Certainly it can happen if that intimal flap goes across one of the coronary vessels and they present very similar to something like acute coronary syndrome as a result of malperfusion of those coronary vessels. They may have that acute onset, but then it comes into a gradual onset of a dull pressure-like pain, which we'll talk about character very shortly. But if you have a patient who comes in with acute onset, sudden onset, and maximum severity of intensity of pain within a very small amount of time, usually within a few minutes, dissection should be something that we should absolutely and 100% be thinking about. Second, we talk about location. Location is also very important in terms of patients who come in with dissection. Now, obviously, patients who come in with chest pain, it should be one of the 5 things that we think about when patients who come in with chest pain in terms of deadly diagnoses that we certainly don't want to miss. But we have to remember and recall that aortic dissection doesn't always present with chest pain. It can also present with things such as back pain. As a matter of fact, type B dissections is more commonly to present with upper or lower back pain causing their dissection causing their back or abdominal pain. So remember that back pain is much more commonly to present in patients who come in with type B dissections. So certainly chest pain isn't the only thing that patients can come in with. There's also a small subset of patients who come in with painless dissections. So remember that as well in terms of you're thinking about your differential. But the other thing to remember is that these patients may be experiencing migrating chest pain. So in other words, the chest pain starts off in one area, and then 5 minutes later, oh my gosh, it's actually moving. Oh, now it's in the upper chest. And now it's going into my even higher chest. And then it's going into the back in between the scapula, which is the classic description. But if we have a patient who comes in with migrating chest pain, again, think about aortic dissection as a probable cause of their pain. Next, and very importantly, is the character. Character is probably the thing that helps differentiate aortic dissection from other causes of chest pain. So let's talk about one thing that really brings a lot of emergency physicians consternation, and that is the pain scale. Pain scale is super important, not only from a perspective of obviously documentation, but even going back and looking at the chart. So oftentimes patients will come to the emergency department complaining of pain, and they will oftentimes rate their pain somewhere between an 8 and a 10. And as you see here on this pain measurement scale, that is listed as severe chest pain. And the plaintiff lawyers will use this against you in their malpractice case to say, this patient who came in with an 8 out of 10 or a 9 out of 10 chest pain, you didn't think about aortic dissection, and I don't understand why. Oftentimes we will go in the room and see patients and ask them what their chest pain is or how bad their pain is, and we'll see them playing on their iPhones or doing something else. They'll say, yeah, I'm in 10 out of 10 pain. One of the important things to characterize and certainly document on your charts is I like to explain to my pain patients what 10 out of 10 chest pain is. I tell them it's the worst pain possibly imaginable. And the analogy that I like to use is, imagine you were walking across the street, you get hit by a truck, it knocks all your arms and legs off. You're laying there, no arms, no legs, and a bird lands on your forehead and starts poking your eyeballs out. Now, obviously, you would be screaming in pain in that circumstance. You're going to tell me that you're still in that pain? That's 10 out of 10 pain to you? Sometimes they'll still say, yep, that's exactly what I feel like, and go back to playing on their phone. But in most circumstances, they'll say, oh, yeah, that's unimaginably, I can't even imagine how much pain that would be. So maybe I'm more like a 6 or a 7 out of 10. And that's very, very important to document on your chart, especially documenting what they in general look like. So you don't document things like the patient was playing on their phone, or certainly that they were doing something else or talking to another patient or another family member or something on the phone. You want to document there's no acute distress. The patient appears comfortable. And those things can sometimes work for you in terms of malpractice cases for aortic dissection. Now, obviously, remember that patients with aortic dissection can have their pain initially, and then a few hours later, it may go away. That is normal, and that's perfectly fine in patients with dissection. But it's important to characterize exactly what happened when their symptoms began. Another thing that patients like to characterize their aortic dissection pain as is stabbing pain or sharp pain. That's much different from the typical pain that we see with acute coronary syndrome of that dull kind of pressure-like pain. And that's certainly important to characterize on your chart. If you have a patient who comes in with dull pressure-like pain, it's less likely to be aortic dissection. But if you just write chest pain and don't really characterize the pain, the plaintiff lawyers will have a field day with your chart. Another thing that patients like to describe their dissection chest pain as is tearing or ripping. And that's commonly that tear as it's propagating down the aorta. They may experience that initial tearing or ripping pain. If patients describe that pain, obviously that's things that you want to evaluate for aortic dissection. But if there's absence of that, certainly it's something that you can write on your chart. Certainly ask the patients if they're having a ripping or tearing pain, especially if you're a little suspicious. And if there's absence of that, certainly that can help you. Another important thing to remember and think about with OCAR is associated symptoms. This is extremely important with aortic dissection, primarily because remember that the aorta is not a singular organ or a singular vessel. The aorta supplies blood to the rest of the body. So just because they have a dissection in the aorta doesn't necessarily mean that they may not have other symptoms. For instance, they may have chest pain and stroke-like symptoms if the dissection flap occludes one of the carotid vessels. They may have renal malperfusion or mesenteric malperfusion that may bring about refractory hypertension or oliguria or anuria. Patients oftentimes are probably not going to be able to tell you, oh, I'm urinating a little less frequently than I usually do. But they may be experiencing abdominal pain in addition to the chest pain, which brings the old adage, pain above and below the diaphragm. So if you're documenting that on your chart, certainly we should be thinking about aortic dissection. Another one that sometimes does occur is chest pain and leg pain if it goes across the femorals or the iliacs. This brings about the chest pain plus one scenario. So if you have a patient who's experiencing chest pain plus another symptom, we certainly should be thinking about dissection. But surely do not, and I've seen several cases of aortic dissection malpractice cases where physicians try to explain away the other complaint. They come in with chest pain and left leg pain, and we try to say things like, oh, well, the chest pain was super important, so I evaluated the patient for the chest pain and completely disregarded the other complaint. Certainly, that is a recipe for disaster in a patient who subsequently may be found to have a dissection. So certainly, you should be finding out what's causing the other complaint. And if you have a good explanation, obviously patients may come in with chest pain, they may have fallen, and may have abdominal pain because they hit something, or they may have leg pain because they fell down and injured themselves. If there's a way to explain it, certainly that's things that we should document. But if they have no real good explanation, and certainly if they began at the same time, think about aortic dissection. Which brings about our first pro of the day. Make sure to document pain in detail using OLCAR. Now, this goes across all complaints. Any type of pain, we should be documenting OLCAR. But certainly in patients who may subsequently have chest pain, who we think about aortic dissection, be sure to document OLCAR. And secondly, do not disregard the other complaint. That is, again, a recipe for disaster. Now let's look at risk factors. What are the things that should increase our suspicion that a patient may have an aortic dissection? Certainly, this is our most common patient population. So usually elderly males, and we'll say, not necessarily elderly for the 50 and 60-year-olds out there. 50 and 60 are certainly the new 30 and 40. But if patients are in their 50s and 60s, and certainly into their 70s and 80s, this is a very, very high prevalence patient population to develop an aortic dissection. Hypertension being the most common risk factor for patients to develop an aortic dissection subsequently. But there's other things that we certainly need to think about, which brings about pitfall number 2, eliminating dissection from the differential due to a lack of known risk factors. So a very common example is very similar to the case that we had. We see a younger patient in their 30s and their 40s, and they don't really have a lot in the way of medical problems. Now, a lot of this patient population also don't go to the doctor. They may not have any known diagnoses, but certainly they may have some underlying diagnoses that they just may not be aware of that certainly puts them at higher risk for developing dissection. A really good example of this is Marfan's. And Jonathan Larson, the author of Rent, unfortunately died from an aortic dissection as a result of the fact that he was young, he was relatively healthy, but he had undiagnosed Marfan syndrome. So certainly if you have a tall, skinny, male or female, may have that kind of high arching palate if you happen to look, but certainly skinny, tall, younger patients, we certainly need to be thinking, could this patient who has the acute onset of chest pain that is severe have an aortic dissection due to undiagnosed Marfan's? Cocaine. Cocaine is a big risk factor for aortic dissection. The problem with cocaine is that we oftentimes associate cocaine with coronary vasospasm. So patients get cocaine ingestion, they get the coronary vasospasm. The unfortunate reality is that patients who come in with that coronary vasospasm as a result of cocaine ingestion oftentimes have very similar to acute coronary syndrome, dull, gradual onset pressure like chest pain. With dissection, which usually comes as a result of the catecholamine-induced hypertension, tachycardia as a result of the cocaine, they come in with the acute onset, again, sudden onset of severe chest pain. And oftentimes our head goes quickly to the coronary vasospasm. But if it's acute onset, very shortly after using the cocaine, certainly we should be thinking about aortic dissection on our differential. Patients may have had a history of some kind of aortic instrumentation. They may have had an aortic valve replacement. They may have had a coronary catheterization. And again, if they've had a coronary catheterization, these patients we oftentimes think about as having acute coronary syndrome. But if the pain is characterized differently, remember that wire for the cath that they're experiencing, that wire may hit the aorta on the way up and certainly cause a small, tiny defect in the intima of the aorta that may subsequently lead to, down the line, an aortic dissection. And there's certainly many, many case reports of patients having this happen. So if they've had some type of aortic instrumentation, we should also be thinking about, in patients who come in with that sudden onset chest pain, dissection. And yes, even our pregnant patients. Pregnancy is a big risk factor for aortic dissection, especially if they have one of those underlying connective tissue disorders like Marfan's, Ehlers-Danlos, and things of that nature. 50% of patients who were under the age of 40, females under the age of 40, who subsequently had a dissection, were pregnant in their third trimester. So this is a big patient population, usually as a result of the many vascular things that happen to the vascular as a result of the hormones and pregnancy. Also remember that the blood volume increases in pregnancy as a result of the fetus, and certainly that can put patients, especially who have connective tissue disorders, at high risk for developing a dissection. One of the very important things to make sure that we do in patients who come in with any type of chest pain, certainly for someone who's thinking about dissection, if they're younger especially, is to take a peek at the EMR. Oftentimes the EMR, especially the good ones like Epic, have a lot of the different possible past medical history, past surgical history, family history, and social history that we may not, or the patient may not be aware of when they present to the emergency department. So they may have gone to a physician some point in time down the road and had a blood pressure checked and they have uncontrolled hypertension, or they got diagnosed with Marfan syndrome when they were young, but they haven't seen a doctor in 20 years and they didn't remember anything that was in their past history. So looking at the EMR can certainly be helpful in terms of differentiating if there's any potential risk factors for a patient having a dissection. So be sure to check the EMR in terms of looking for known risk factors that the patient may be unaware of in your patient who comes in with chest pain. Which brings me to pro number 2. Remember that young people can have dissections too. And this is a very frequent miss that we have in our patient population, is the younger patient who comes in with chest pain. We oftentimes write it off. And unfortunately, as a result of that, there is a higher risk of malpractice as a result. So be sure to check the EMR, verify past history elements in your patients who come in with chest pain. Then let's get to the physical exam. The physical exam is very important also for documentation purposes, but there's a common theme in the malpractice cases that I've seen for dissection that we definitely need to avoid. And that big pitfall there is over-reliance on relatively normal vital signs. So we all learn in residency and medical school that patients who have a dissection more commonly come in with severely elevated blood pressure. So we see blood pressures of 220, 240, 250 systolic blood pressures with patients who have a dissection. In reality, though, that only happens 49% of the time. According to the International Registry of Aortic Dissection, otherwise known as IRAD, 49% of patients come in with elevated blood pressure. Now, elevated blood pressure, according to IRAD, is anything higher than 140. Now, I know in Baltimore, and actually subsequently in San Antonio, when I see a blood pressure that's 120, 130, that patient has to be septic until proven otherwise. Patients come in walking and talking to the emergency department with blood pressures in the 200s, and they look perfectly fine. When I see blood pressures of 130 or 140, I'm starting, should I think about pressors in this patient population? But with aortic dissection, it's actually more common for patients to present with normal or even low blood pressure. Now, why would a patient who has an intimal flap and subsequently decreased perfusion subsequently have a lower blood pressure? And it's commonly as a result of that intimal flap. That intimal flap, which goes across one of the subclavian vessels, may cause decreased perfusion. And oftentimes we only check one side. Now, this isn't something that we want to document that the patient may have this large discrepancy because, again, that's actually very common in the general population. So we don't want to document the blood pressure in both sides. But if that intimal flap is going across the vessel, we should not be reassured by normal vital signs. Secondly, and very importantly, the patient may have experienced some type of complication that has led to the decreased blood pressure, such as tamponade. Tamponade is the most common fatal complication of aortic dissection, and it is certainly a cause of death in patients who come in with aortic dissection and can certainly lead to a decreased blood pressure. Another pitfall that we commonly see not documented on charts is a failure to check and document pulses. So very commonly, I see a patient who comes in with chest pain. we're going to stick into the radial arteries and checking to make sure that the pulses are equal. But we oftentimes forget about the lower extremities. So it is important that we check all four extremities and document in all four extremities that the pulses are equal and that they're comparable to each other in all four extremities. And the last pitfall is failure to check for and document murmurs. If the patient has a murmur, it's certainly something that we should think about, especially if they have an aortic insufficiency murmur, which is the most common murmur that patients with an aortic dissection subsequently manifest. 40% of patients who have a type A aortic dissection will have an aortic insufficiency murmur on exam. So it is important to document absence of a murmur in patients who come in with chest pain. Brings us to pearl number 3. Make sure that we document that patients have all four pulses in all four extremities and that they're equal and that there's no murmur. But the more important pearl here is making sure not to rely on normal vital signs for patients who come in with dissection. If their vital signs are normal, it is imperative to not say, well, the patient has normal vital signs, therefore they do not have an aortic dissection. And we're going to briefly talk about clinical decision rules, primarily because plaintiff lawyers are actually familiar with them. So they know about PERC, they know about the heart score, and they know about this relatively newer aortic dissection clinical decision rule, which is the ADDRS, the Aortic Dissection Detection Risk Score. This primarily is made up of 3 common components in a patient who comes in with history and physical for dissection. I'm going to briefly show you what they all are, and as you can see, a lot of them are things that we've already discussed. So if they have Marfan's or some other connective tissue disorder, some history of aortic surgery, personal history of aortic disease or aortic valve disease, any torso pain, severe, sudden tearing, certainly should be thinking about dissection. If they have an aortic insufficiency murmur, hypotension, again, not hyper, but hypotension, and any neurodeficit or pulse deficit, certainly these are things that we should be seeing in patients who come in with dissection. So guess what the plaintiff lawyers are going to look for on your documentation in your patients who come in who were subsequently found to have a dissection is this ADDRS, all of the components of this ADDRS. And so if these things are not documented, certainly that lowers the risk and certainly gives you a little bit of a leg to stand on if you were to subsequently get sued for a missed dissection. However, if some of these things are present on your chart, again, you need to make sure that you document why they may have had these things or be looking for an aortic dissection. The problem with the ADDRS is it's okay in terms of usefulness in the emergency department. What the ADDRS was supposed to do was to kind of be like the PERC rules for aortic dissection. Nazarian et al. Looked at using ADDRS plus D-dimer in terms of kind of putting a pretest probability on your patients who come in with chest pain in terms of if they may have an aortic dissection or not. So if their score was a 1, which if you look at the ADDRS components, anything that's in any of those categories gives them a 1, a 2, or a 3, depending on which category that they're in. So using the ADDRS plus D-dimer was found to be subsequently sensitive. So Nazarian et al., first with a retrospective study, which was published in July of 2014, found that it had a pretty decent sensitivity, 100% if the D-dimer was negative and the ADDRS was 1, and 87% if the D-dimer was negative and the ADDRS was 1 or lower. But then he did a prospective study, which is the ADVISE trial, which was published in 2018, which again had pretty decent sensitivity. Sensitivity was 99.7 and 98.7, depending on what the score was. Now, the problem with the ADDRS, I think, is that primarily, if you look at the components, again, if they have none of the components of ADDRS, then why are you even looking for an aortic dissection? Why are you getting a D-dimer to look for aortic dissection? You should be thinking about what other things could be going on. But the other problem with the ADDRS is that the specificity, according to both of these studies, was about 60%. But the prevalence in this patient population was 13%. Now, I don't know what emergency department setting that you guys are practicing in, but if my population of patients had a 13% prevalence, aortic dissection is probably going to be number 1 on my differential diagnosis. So Oli et al. Looked at what about the low prevalence population, which is more commonly what we have primarily in the United States. And what they found is that the specificity, so this was a 3.2% prevalence, the specificity significantly plummeted. So 12.3% specificity for patients who come in with chest pain with the ADDRS plus D-dimer. So it's probably not a useful score for our patient population. Sensitivity is still pretty good, but this is not something that I'm going to document on my chart to say, hey, the ADDRS is 0. I don't think that this patient has a dissection because of the fact that the ADDRS is 0. But it's something that the plaintiff lawyers may be looking at and certainly may be using in the future. And I've seen several of them try to use the ADDRS, but it's probably going to be something that's a little bit more prominently used so subsequently in the future. Lastly, let's talk about the diagnostic workup. So patients who come in with dissection, we certainly, if we're suspicious, we're going to do some things in terms of figuring out what the diagnosis is. So first and foremost, a very big pitfall is the over-reliance on diagnostic tests with less than adequate sensitivity. So we know the chest x-ray is very, very poor for ruling out dissection. However, despite the fact that this is a very commonly known thing, certainly it's even taught in medical school, I see physicians saying that the chest x-ray shows no evidence of wide mediastinum, therefore I don't think dissection is on the differential. And obviously this is a very, very big no-no. 60% of patients who have an aortic dissection will have a finding on their chest x-ray, which means 40% will have a normal chest x-ray, a normal mediastinum, and subsequently still have a dissection. That's a very large mispopulation. Some of us are very prominent with TEE, and TEE is a very useful tool for ruling out dissection, has a very good sensitivity and a very good specificity, certainly in the arms of a veteran user, someone who's certainly not a novice. But if you're very good with TEE or you have TEE available, especially in your unstable patients, this is a modality that you can certainly use. What about our old friend TTE though? Is this useful for ruling out dissection? Well, it's very good for ruling in dissection. So you can do a transabdominal view, but you can even do a suprasternal view and get a pretty decent look at the aortic arch. And so here's one that was done that showed a very nice intimal flap. And then here's a transabdominal one that was done by one of my colleagues that again has a very nice intimal flap that's very visible. And if there is an intimal flap present, the likelihood is that there is a dissection present. There's a pretty good, again, specificity, but the sensitivity is not great. So this is not a modality that we should be using primarily to rule out aortic dissection, but certainly can be one that's used to rule in. And I've had a few patients, a handful of patients who have actually gotten to the OR with simply doing a suprasternal view and a transabdominal view, documenting that there was an intimal flap and a dissection was subsequently there, and the CT surgeons took the patient to the OR. We know the CT scan is our friend. CT scan is the modality of choice, the gold standard for diagnosing patients with aortic dissection. It does a lot of things for us. It looks at the obvious luminal irregularities, but it also does things like look for malperfusion of different organs, looks for if there's mesenteric malperfusion, if there's renal malperfusion. Those things can be evident on the CT scan and can help in terms of if the CT surgeon or the vascular surgeon may need to do something called a fenestration procedure, where they'll actually poke holes in the intimal flap to reestablish perfusion to those vital organs. One of the things that precludes physicians from getting a CT scan and has been one of the sources of many causes of malpractice is let's wait on the creatinine, or let's not get the CT scan because the creatinine is elevated. And Batman says, forget. That's not a cuss word. See, you got your minds in the gutter. That's 6 letters, F-O-R-G-E-T. That's not a 4-letter word there. That's forget the creatinine. But you don't want to think about the creatinine in a patient who you have a high suspicion for dissection for. The creatinine doesn't matter. This is a life-altering diagnosis and certainly can be a life-ending one. And so if the patient subsequently goes on dialysis, and you know how I feel about contrast-induced nephropathy, but if they're at high risk for dissection, forget about the creatinine. Just go ahead and send the patient to CT scanner if you need to document to your CT techs the risks are certainly outweighed by the benefits of the CT scan. Make that documentation and send your patient to the scanner to get the CTA done and the appropriate diagnostic study done. Another common thing that I've seen in some malpractice cases is using a CTPE to rule out dissection. Now, the specificity for CTPE is actually pretty decent for a dissection. So if you see an intimal flap, certainly that patient more than likely has a dissection. But it's not a great useful tool if the CTPE does not show a dissection. And that's because of the timing of when the contrast bolus goes through. So here's a really good example of a patient who had a CTPE, subsequently found to have a CT showing a dissection. And as you can see, as a result of the bolus differences, you'll see a little bit of schmutz inside the lumen. And all that is the contrast bolus moving through the aorta at a very quick fashion because of the timing. And that unfortunately can miss a dissection flap, as opposed to this, which is an appropriate CTA to rule out dissection, where the timing was given at the appropriate timing. And as you can see here, they saw a very nice intimal flap on this dissection study. This was the same patient. CTPE was negative. CT of the aorta showed a dissection flap, subsequently making the diagnosis. Brings me to pearl number 4. TTE is good if you find it. It's not great if you don't find it. So it's not a great tool for ruling out dissection. But very importantly, order the appropriate test. If there is any true concern for a dissection, order that CTA, chest, abdomen, and pelvis, and put as the indication to rule out dissection. So I'm going to briefly wrap up these some very quick take-home pearls. I know there's some questions that may have popped up on the chat, and certainly I'm happy to answer. But in my quick wrap-up of take-home pearls, I'm going to try to hammer home the following key points. 1, using old CAR in terms of characterizing and describing any pain complaint, but especially chest pain, back pain, or abdominal pain. Torso pain that's sudden onset, severe, think about dissection as a potential cause. Do not ignore that other complaint. Chest pain plus another symptom is dissection until proven otherwise. If the patient has abnormal vital signs, that is not an indication to rule out dissection. Make sure that you also check the EMR to look for other potential risk factors such as undiagnosed hypertension, undiagnosed Marfan syndrome as potential increasing their risk for dissection. Remember to check for all 4 pulses. Compare the upper and lower extremities and the left and right side to make sure that you're not missing a pulse deficit, which can help in terms of making sure that you don't miss a diagnosis, but also very important to document to show that you at least thought about the diagnosis. And last, do not rule out dissection based off of inappropriate diagnostic tests. Your TTE is not good enough by itself to rule out dissection. Your CTPE is also not good enough to rule out dissection. Get the appropriate study if you think it's warranted. And with that, I thank you for your time. It has been an absolute pleasure to be here with you. I miss you guys, and it has been wonderful to be here. Thank you. I'm happy to entertain any questions.
Thanks so much, George. That was just simply an outstanding way to kick off our emergency cardiology symposium. So many pearls in there. You covered the gamut from presentation to diagnostic testing. You know, as you were speaking, it reminded me, I think, of the last 2 cases of aortic dissection I've had actually have been in younger folks who presented with abrupt onset back pain, weren't markedly hypertensive, but had the risk factor of sympathomimetic use that ended up being or having aortic dissection. So you really helped us quite a bit in terms of outlining those risk management medical malpractice pearls and making this critical and potentially life-threatening and life-saving diagnosis and subsequent treatment. So my thanks to get things started off in an outstanding fashion. Let me turn things over to Dr. Ablahed to see if she has any questions from the chat window.
Hey, George, can you hear me?
Yep.
How are you?
Good. How are you?
Good. So this generated some discussion on the chat. I also want to say you've taught me everything I know about dissection, and I'm still fearful to this day. So thank you. one question was, if the patient has chronic hypertension, well, and we know like dissection is a complication and or can be the risk increased by hypertension. But if somebody has chronic hypertension, can they have a type B dissection that is in a chronic process? Do we need to work them up? And how do we worry about those who has developed a chronic type B that was not diagnosed in the past?
So absolutely. So chronic type B dissections are common, and most commonly as a result of the fact that these patients, again, present with back pain or abdominal pain, and they may not have any malperfusion. So usually the thing that causes type B dissection complications are things such as rupture and then malperfusion. So if they've knocked off the mesenteric artery or if they've knocked off the renal artery, that's certainly going to increase their mortality. But if they have an intimal flap that doesn't occlude any of the branch vessels, they can do perfectly fine. They may not present to the hospital. They get their back pain and their symptoms go away. And then they think, oh, I'm fine. There's nothing wrong with me. And then they get subsequently a CT scan for something else, like maybe appendicitis or some abdominal pain. And then they're found to have a type B dissection. I've had a number of those chronic type B dissections. In other words, they have an intimal flap that may have clot in the intimal flap because it's been prolonged. It's been years since they actually had the inciting event. Most oftentimes, those actually do pretty well without any management. They oftentimes will get blood pressure control. Sometimes they'll intervene, but a lot of times with the chronic type B dissections, vascular surgery doesn't necessarily go for putting a stent in. And the most common reason why is because that intimal flap has clot behind it. So you don't really necessarily need to stabilize against that clot burden, and it's difficult to stabilize that clot burden. So as long as the patients are asymptomatic, a lot of times they will just do blood pressure management, heart rate management, and let those patients go on. They'll be watched in those circumstances. But if you were found to have a chronic type B dissection, most of the cardiothoracic and vascular surgeons, consult obviously, but it's not necessary that they may actually say that's a chronic dissection, treat the patient for whatever they came in with, where they were subsequently found to have the type B dissection, the chronic dissection, and then we'll just follow along with them in the clinic, and it's okay to send those patients home.
Another question about sentinel chest pain. Is there such a thing as a sentinel chest pain that the patient might have presented with before the catastrophic tearing, ripping chest pain when they're about to see death's door?
That's a great question. Yes. So I didn't talk about this, but there are some what I like to call pre-aortic syndromes, pre-aortic dissection syndromes. So there's intramural hematoma, penetrating ulcer. And so those may be that initial event that the increased blood pressure causes a defect in the intimal flap, or a defect in the intima of the aorta, but doesn't necessarily cause a full-blown dissection. And so the patients may present with that chest pain that comes on acute onset, may even be described as moderate, but most of the time it's still characterized as severe, and they don't have anything that shows any malperfusion. You get a CT scan and you see a penetrating ulcer, or you may not see anything at all, depending on if the study was done appropriately. Most of those will typically have still be managed. CT surgery and vascular surgery will still oftentimes manage their blood pressure, but they won't necessarily do any intervention on those. But there is such thing as chest pain, the sentinel chest pain that can occur with dissection. One of the very important things that I've learned over my many years of study of this is that patients can have the sentinel chest pain and then the chest pain completely go away. So that dissection flap may occur. They may have a full-blown dissection as well, as those pre-syndromes. But as a result, they may their pain may go away, and that is not a way to rule out dissection. So it's very important to think about that as well.
And just to stay on time, one quick question, and then I'm going to have you answer the rest of the questions on the chat, if you will.
Yep, absolutely.
Bilateral blood pressures, yes or no?
I'm not a fan of it for ruling out. I do use it for management in terms of where I put my arterial line. And so I stick it in the side that has the higher blood pressure, because I don't really necessarily care about the lower arm. if I put it in the one with the lower arm, they may still have blood pressures of 190, 200 in the other arm. And I'm thinking that with my antihypertensive agents that I'm doing a good job when I'm actually not. So I will check blood pressure on both sides, and I will put the arterial line in the one that has the higher blood pressure. I will put it on the side that has the higher blood pressure so that I know that I am maximizing the blood pressure control with my antihypertensive agent.
Great, beautiful, thank you. I will have you answer some questions on the chat.
Sure.
Dr. Winters.